I think we have the chance for a few questions, if there are any questions. Because probably there are some practical questions from the audience. Yes. Yes.
Congratulations for your talk. I'd like to know about the portion of patients like those with a chronic kidney disease. Those they have osteoporosis, but they have also renal osteodystrophy, something very complicated. And I think that in this FRAX probability, anyway, we have to have some information on the renal function.
So I think the question, just for those, for those of you at the back, the question is really around complicated osteoporosis or secondary osteoporosis, where patients will have underlying complications such as renal osteodystrophy. And so this is a tool for straightforward postmenopausal and age-related osteoporosis in men. That doesn't mean that secondary osteoporosis disappears tomorrow. It's part of the education that we have to get out to the general community, that there are these patients with complex disease that need to be managed in expert centres, and that doesn't change. So whenever, I'll just give you an example of whenever we first proposed FRAX. One of my colleagues in Sheffield said, this is dangerous, because let's say there's a lady out there who has some vertebral fractures, and unknown to the primary care physician who's looking after her, she has multiple myeloma. And he does the FRAX, and he says she's osteoporotic, and puts her on a bisphosphonate, and he doesn't investigate her appropriately, and she's diagnosed with multiple myeloma 6 months later, or whatever length of time. And I said, that it may be true, but what's happening to that woman today? She's not getting her osteoporosis treated, or her bone disease treated, and she's not getting her myeloma treated because she hasn't presented yet till 6 months down the line. So I don't think we're doing patients a disservice. We need to do an education program around what is osteoporosis, what are the secondary causes of osteoporosis that we should be investigating in particularly high-risk patients, and what's the best management, what are the best drugs to use in the setting that we say. Renal osteodystrophy is a disease unto itself that should be managed in highly specialized centers.
Okay, as hyperparathyroidism, who also exists in renal dystrophy, it's a different disease and also can produce high risk for fractures, but this model cannot be used for the FRAX too. Any more questions, please, for Professor Matrosky? Yes. Can you wait first? Oh, okay.
Thank you. Congratulations. Excellent presentation, very useful. I've got one question. We know that there is a percentage of young postmenopausal women, about 25 to 30%. If you do a BMD here, at least you mentioned we have a lot of easy access to BMD. So, and some centers that we do both the spine and the hip. So there is a discordance, about 25–30% discordance between spine and hip BMD. So say the hip is completely normal and the spine is obvious osteopenia, okay, or osteoporosis. Now, are you thinking of include the BMD of the spine in the FRAX for this young?
There are two good points, or several good points you make there. The first one is young patients. So the cohorts in which we've built FRAX, the youngest age that we can go down to is 40 years of age. So we don't really have good epidemiology for the relationship between bone density and fracture risk in young adults, for example. So that's the first thing. You can't enter a 35-year-old into FRAX. You can make her 40 for the sake of the exercise, but it won't calculate unless the age is 40. But the other thing is the discordance between the femoral neck and the spine. And again, not in particularly younger patients, but we've been able to explore that issue in older patients. So Bill Leslie in the Manitoba cohort, for example, looked at the impact of discordance between the lumbar spine and the femoral neck. And he published a paper last year in which there was... Well, the average age in the Manitoba cohort is about 65. Yeah. But in that population, he found that for every 1 standard deviation difference between the lumbar spine and the femoral neck, then you should adjust the fracture probability by 10%.
So you upgrade the
So if
by 10%.
If the lumbar spine is 1 standard deviation lower than the femoral neck, you add not 10%, but 10% of the measured probability. So if the patient's 20%, it goes up to 22%. So it's actually quite a small impact. 22%. Yeah, so it's 10% of the probability that gets added to it. Likewise, if the lumbar spine is 1 standard deviation higher, then you can downgrade it by 10%. So that's a rule that has been published by Bill Leslie. That's the first cohort in which it's been looked at. At the ECHIO meeting in Bordeaux this year, we presented a similar analysis in lots of other cohorts, and the 10% rule seems to be about right.
So the difference is not too big, but you have to increase the risk about 10% for each SD. We have one more question by Dr. Katsalira.
I would like to ask something about the people who took or have taken medication for osteoporosis. We have to induce FRAX algorithm for people who have not taken medication, but also for people who have taken bisphosphonates 2 years ago, or the other medications 1 year ago, I think. How do we explain that in terms of 2 years?
Okay. Whenever we first produced FRAX, we said it shouldn't or is not to be used in patients on treatment. Why did we say that? We said that because the cohorts that we used to build it didn't have anybody on treatment. They were just population-based cohorts. However, as a clinician like yourself, I often have patients in the clinic who have been on bisphosphonates for a year or two. Generally what I have is, I also have their bone density from before treatment. So I can actually look back retrospectively and see what their risk was before they went on treatment. And then, if I know that patient, and I know that they're a good patient, they're a compliant patient, and their bone density has gone up, and I'm seeing good response, then I know that what I've estimated their risk to be is almost certainly an overestimate based on their effective treatment. So that's how you can use it in an individual. Bill Leslie, again, has just looked at this question because in the Manitoba cohort, he had a population of a few thousand women who were on treatment, and he looked at the relationship between the predicted fracture probability and the observed fracture incidence, and perhaps a bit depressingly, found that the predicted and the observed were pretty much identical. So the patient's risk before treatment was the risk observed on treatment. And there's a number of possibilities for that. But I think the most common possibility is that our patients in the general community are pretty poorly compliant with their medications. And you don't get good efficacy unless you're a good compliant patient with medication, because we're looking for a 20–25% reduction in non-vertebral fractures, which are the most common fractures that patients will get. And you can see that in a clinical trial where everyone is followed up and encouraged to take the medicines and all the rest of it. But out there in the community, patients don't take the medications, or if they do take them, they don't take them correctly. So I think there's issues around compliance and how we educate patients. If you're at high risk, you actually need to take your medication. If you're not taking the medication, what are we going to change you to improve your compliance?
So, if there are no more questions, thank you very much, Eugene. I think we'll have the chance to see you soon again.